All right. We are back from executive session. First up, we have Ryan Ramsdell, UMP Team Manager in the Herb Division, is going to be providing some information on the proposed plan year 2026 benefit changes for the Uniform Medical Plan. Ryan's going to introduce a couple resolutions today, but no action is scheduled for this meeting. We anticipate asking the board to vote on these resolutions at our next meeting on July 10th. Materials behind tab number 4. Ryan, welcome.
Good morning, Chair McDermott, members of the board. My name is Ryan Ramsdell. I am the UMP TPA Team Account Manager. Today I'll be talking you through a couple of items related to the Uniform Medical Plan. The first one is more informational. It is related to the IRS Consumer Directed Health Plan update and deductibles. And then I will move into an update on UMP hearing instruments and provide you a resolution proposal. Next slide, one more. So this is a reminder that there was a resolution that was in effect for January 1st, 2024, where HSA shall set the annual deductible for the UMP high deductible health plan at the minimum annual deductible level established by the Internal Revenue Service to qualify the plan as a high deductible health plan. What that means is at that point, as the IRS makes adjustments, the board no longer has to take action. That resolution moves forward. So this is just an update to let you know that the CDHP minimum deductibles for 2026 are now $1,700 for an individual and $3,400 for a family. Any questions on that? All right, so let's talk about hearing aids. Substitute Senate Bill 5262 was passed in 2025, and it made some changes to the language. So many of you might have been familiar last year with some updates, and the purpose of this discussion is to make some refinements based on the new language. So under Section 9, that amended RCW 4843-135, it requires that health plans issued or renewed on or after January 1st, 2026 shall provide coverage for medically necessary hearing instruments every 36 months. And this is the important part, without any lifetime or annual limits on the dollar amount of coverage, whether provided in network or out of network. Previous language had reflected a $3,000 amount within that section that speaks to the annual limit. Next slide. So the change to the language removes the current dollar benefit limit for the hearing aids. That it'll now be covered as a standard benefit without a cost share. Coverage will continue to be the every 36 months requirement. And as a note, member benefit accumulators will not reset on January 1st, 2026. That means that the clock continues to tick, even though this update is occurring. You have that 36-month benefit. It doesn't change because we're making an update here. You should expect similar member experience for in-network providers. And we are going to be providing a series of open enrollment communications regarding this change. Of special note related to the hearing aids is that this is going to be established as an allowable amount. If members choose or opt to purchase a specialty hearing aid that might exceed the cost of the allowed amount due to preference or other reasons, the provider may ask them to sign a waiver to indicate that they've received informed consent and that they would pay the balance of that share. Questions on that? Next slide.
Oh,
go ahead.
Is there any partner with the OIC or anything to make sure that the hearing aid companies aren't going to substantially increase the costs for this?
What I could say is this is the fourth or fifth hearing aid bill that has passed the legislature since 2018. And there's been a lot of activity and changes in this area. And so we as an agency are in regular communication and collaboration with OIC about what's going on with this particular part of benefit coverage. So I think there has definitely been a lot of adjustments, scrutiny, and regulatory oversight in this area. So I think there's a watchful eye on things, and that's the best I can do to answer your question, Michaela. But it's definitely, we are talking about hearing aids quite a bit in the last 6 years, 7 years. And it's definitely an area that people are focused on, and I think will continue to be focused on. There always seems to be something to refine in this area.
All right. So as a reminder, the previous resolution, PEB 2023-03 for UMP hearing instruments, that was adopted on June 8th, 2023, resolved that beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plans will be covered up to $3,000 per year, with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in UMP Classic, UMP Select, and UMP Plus are not subject to the member meeting the plan deductible. Coverage for members enrolled in UMP Consumer Directed Health Plan, CDHP, are subject to the member meeting the plan deductible. Next slide. We're proposing to rescind the resolution, PEB 2023-03, effective January 1st, 2026. Resolution PEB 2023-03, as adopted on June 8, 2023, is rescinded, and to be replaced by proposed resolution PEB 2025-06, UMP hearing instruments, which reads, beginning January 1st, 2026, prescribed hearing instruments in all uniform medical plans will be covered at 100% of the allowed amount every 36 months. Coverage for members enrolled in UMP Classic Medicare with Part D, and UMP Select is not subject to member meeting the plan deductible. Coverage for members enrolled in UMP Consumer Directed Health Plan, CDHP, is subject to the member meeting the plan deductible. Of note, a minor change is that you do not see UMP Plus in there because that plan is sunsetting at the end of 2025.
We'll just leave it on this back on the resolution slide for a moment. The other thing that I was going to highlight for the board is sometimes we bring you resolutions that we do track changes and red lines, and we try to clean it up and maintain with the amount of activity that has happened on hearing aids since 2018. I feel like my entire directorship tenure, we have talked about hearing aids every year in some way, shape, or form. We thought it was best to just kind of rescind and replace in this particular instance to kind of reset the language instead of having to track over time. It's quite complicated actually to track over time the amount of changes that have happened on hearing instruments in the past 6, 7, 8 years. So we thought it'd be good to reboot on that front. We will also anticipate that next year, after the plan closure of UMP Plus has actually happened, we would probably be bringing you additional resolutions to clean up and repeal language that is in your policy statements related to UMP Plus. So this had the added bonus of going ahead and doing that on that particular resolution. So just wanted to point that out as well. And then a reminder that what can be pre-deductible or what's subject to the deductible and the high deductible health plan is really IRS regulated. And so there's not a lot of discretion in those particular instances. But just wanted to remind members of the public and the board of that as well, that there's not really a choice so much there. We're just highlighting the differences that happen in those plans because of the IRS regulations. John, you have a question?
Yeah, my recollection is that when I first joined, our big discussion was allowing Costco to be a provider. And for some reason, the then plan didn't allow Costco. So this plan will allow you to go to Costco for your hearing aids?
I'd have to confirm that. The current status should be any provider that accepts Regents contracts will be eligible for this.
Yeah, the reason I remember this was a big deal. It must have been 2020 or 2000, around there when I first joined. And there was a lot of concern among retirees that Costco had better quality and lesser price. But for some reason, it wasn't accepting our insurance.
I will bring that back and get back to the board on that.
Yeah, I think that really highlights an important point about this future state in 2026. It's more about network status than it is about like a defined benefit. So to compare and contrast a little with vision coverage. So there's a fixed dollar amount, an allowance, if you will, for you to go purchase, and you get a credit or a reimbursement, depending on how exactly you seek the getting your hardware of, $200. And so if you pick a $500 pair of frame, you know that you have your allowance was $200, and that you are picking up the extra $300. That's kind of how hearing aids predominantly work right now. In a future state, it's more about like, am I in network, and what are the hearing aids that are offered to me at that in-network setting that are 100% covered by the allowed amount. And then at the same time, you might be able to turn to another wall and go, and here are other hearing aids that if you want to purchase, you can sign a waiver and allow that you will pay the difference versus here is a hearing aid that is 100% covered by the plan. So it's going to be a little bit of, that's going to feel like a different piece, but the real emphasis that members would want to focus on is network status of where you're going for the hearing aids.
And I don't believe Costco contracts with Regions. I just looked it up. Yeah.
But we'll get some confirmation and
Yes.
check in on that.
100%.
Because
Sure.
yeah, there's been a lot of changes in hearing aids in the last 7 years. I absolutely cannot keep track of the whole history. I know we've had Costco network concerns. We had the topic of where there was no benefit limit and we were paying billed charges, and so we were having a $10,000 hearing aids being covered. And so there was that board resolution that helped align with the state law that set a defined benefit. And now there's this version that gets rid of and moves it to a allowed amount. So there's just a lot of nuance that has changed over the years. But we will, confirm and come back when we bring the resolution for action. Just checking any questions remotely. No hands. Perfect.
All right, next slide. And one more. Thank you. So as per usual, next steps, we'll incorporate any board feedback regarding this proposed resolution. We'd ask that requests for feedback and input be received by July 3rd, 2025. And then we will bring the recommended resolutions to the board for action on July 10th, 2025's board meeting.
I did realize there's one more thing I want to say, Ryan. I don't think you said it today. The underlying bill that's prompting the change in UMP also does apply to the fully insured plans. And they are making adjustments to how they are administering hearing aid benefits to also comply with the Senate bill. Ryan's just going over the UMP part today. And whenever we go over fully insured benefit pieces, we'll highlight that as well. But just wanted to make sure it was clear that this isn't just a UMP thing. It's a market-wide thing, plus UMP.
Any questions or comments for Ryan? Thank you, sir. Appreciate your time. Next up, Laura Ryan is going to be, she is the retired benefits manager in the PERB division, is going to review the plan year 2026 proposed benefit changes for plans in PEB's program Medicare portfolio. Tab number 5. Welcome.
Good morning, Chair McDermott and members of the board. My name is Laura Ryan, and I am the retiree benefits manager. So I'm here to talk about any Medicare benefit design changes for 2026. So today we'll talk about federal changes for the Part D plans, any changes for our PEB program Medicare plans, and some upcoming open enrollment communication plans. Okay, so we'll start with benefit changes. This is fairly brief. This is what we know about federal changes to the Part D plans. We don't currently have the Medicare Part B premiums for next year. Those haven't been announced yet. So what we have for you today is the Part D out-of-pocket cost change. So for this year, the out-of-pocket was $2,000. It is going up by $100 for 2026. So that'll be the $2,100 out-of-pocket maximum in 2026 for the Part D plans. Move on. Thank you. We currently have no proposed changes for Kaiser Northwest, and no proposed changes for Kaiser Washington. For the United Healthcare plans, there is one proposed benefit change. This would be the discontinuation of the Personal Emergency Response System, or the PERS benefit with Lifeline. So this would be to discontinue this benefit at the end of this year. UHC is making the decision based on low utilization of the product and the fact that there's new technology on the market, such as smartwatches that have some additional capabilities like fall detection, things like that. They have identified that we have about 207 PEB members who currently use the service. And UHC is going to be reaching out to each of those members to let them know that this will be discontinued and to talk to them about what their next steps can be. They will have the option to convert to private pay and continue the service with Lifeline. They would get a discounted rate if they do that, or they could just discontinue the service altogether. So in either case, it will be deactivated on their devices the first week of January 2026. Next slide. And then moving on, looking ahead to the communication plan for open enrollment. The open enrollment dates will be October 27th through October 24th. As per usual, the personalized letters are going to be mailed out to members. The open enrollment information is always included in our October retiree newsletter. So that will have the plan options, the premiums, instructions on what to do to make any changes. We'll also have the website updated with open enrollment posts by October 3rd. And then I've put the PEB Medicare email there. Again, if there's additional questions, I can be reached there. Next slide. And that concludes the few things I had for today. Are there any questions for me? Yes.
We have questions.
Men
Your mic,
first.
sir.
Oh, no. My friend from New Jersey.
Gentlemen first.
All right. Going back to slide 4. One of the things that I've been looking at pretty closely is the definition of what is the out-of-pocket expense in Medicare. And it changes yearly in terms of what portion paid for by third parties like drug manufacturers and so forth is included. And this year I was really surprised in that I reached my own out-of-pocket in May.
Mm.
And it turns because there were changes this year in the definition of out-of-pocket. Do you know if there are going to be any changes in the coming year?
As far as the definition,
Yeah.
none that we know of. None that we know of. Again, these are CMS regulations, so we do take that.
I couldn't get an answer. I couldn't get anyone from Medicare to answer the question. So
Yeah, we would anticipate that it would be the same as last year, with the exception of the cost going up by that $100.
yeah, because it's a formula rather than simply how much do you spend out of pocket, because part of the contribution of this 2,000 comes from the pharmaceutical companies.
Yeah, there's definitely been changes in recent years that I think the important part that Laura highlighted is that a lot of the exact formulas are in CMS regulations, so they are subject to change. There's no reason to know that they or think that they are eminently changing, but I think the hard part is, and anything can change at the federal government level, and so getting a 100% committed firm answer is elusive, I'm sure, John.
Am I correct when you talk about Part D plans that it also includes the ones that you get on the market?
Yes.
If you're under Plan G?
Yes, that's correct. So
Okay, I just
same
like to be
regulation.
Sure, I
Mhm.
get it. All right, thank
Yep.
you.
Other questions or comments?
Just a reminder, I know everybody's anticipating when open enrollment is. You've got 121 days, 14 hours, and 7 minutes before we go live at 12 a.m. on October 27th. So we're really close, actually. So 4 months is really close. We're closer to the new open enrollment than we are the last open enrollment.
You really need to increase your attention to detail.
Yeah. I could do second, but our state phones don't really do that as easily.
All right. Thank you, Laura. Appreciate it. Next up, Molly Christie, fiscal analyst in Finance Services and Healthcare Purchasing Administration, is going to provide us some information regarding the plan year 2026 Medicare premiums. She'll also be introducing some resolutions related to the 26 Medicare premiums today, but no action scheduled for this meeting. We're going to be voting on them on the 10th of July. Materials behind tab number 6. Molly, welcome back.
Thank you, Chair and members of the board. For the record, again, my name is Molly Christie, and I'm here to present the proposed plan year 2026 Medicare premiums. Next slide. So before I get into the rates, I wanted to provide a current look at our enrollment across plans. This slide shows the membership counts by plans as of May 2025. Compared to the same time period last year, we've seen some stabilization in membership for UMP. During open enrollment, there was a decrease of about 4% of members in the plan. You might recall that in prior years, we had a significant decrease in membership by about 20,000 members over several years. So this is really good news to see the plan stabilizing. United grew about 20% for its complete plan. That has the vast majority of membership. We have two plans for United, complete and balance, and most of the members are incomplete. Primera Plan G also saw a 23% increase in membership. Kaiser Washington lost about 10% of members, or just over 2,000 people. And Kaiser Northwest remained relatively stable, falling about 2% compared to 2024. Next slide. This table shows the 2026 proposed single subscriber Medicare retiree premiums after the explicit subsidy, as well as the percentage and dollar change compared to 2025. As a reminder, the legislature for 2026 established the Medicare explicit subsidy cap as $183 or 50% of the premium or bid rate, whichever is less. These premiums also include the benefit changes Laura described, so I won't go over those again. She just mentioned those. You can see that premiums are increasing for United Complete and Kaiser Washington by about 21% and 24% respectively. Carriers shared that rates are increasing primarily due to claims outpacing growth in CMS revenue for MAPD plans. This shifts cost to members via higher premiums. The Primera supplement plans are also experiencing rate increases due to higher utilization. As you see, and we present this every year, we have separate rates for members who are eligible for Medicare due to a disability versus members who are eligible for Medicare due to age. That appears as retired. So you see rates for Plan F and Plan G, retired and disabled. The difference in those rates is really due to increased utilization, increased medical costs for members who are eligible for Medicare due to a disability. Alternatively, the only red value you see here is a decrease for UMP, which is nearly $50. It's a decrease of about 12% over 2025. And in a few slides, I'm going to describe some of the reasons why we're seeing this decrease for UMP. The next slide shows the same monthly single subscriber premiums, as well as the monthly subscriber and Medicare eligible spouse or state registered domestic partner premiums. So in this case, we're talking about two Medicare eligible members, and it's a pretty simple formula. It's the monthly premium for a single subscriber multiplied by 2 minus the self-pay admin. Because the single subscriber premium already has that self-pay admin charge included, we don't charge it twice for a single account. Next slide. This slide shows the value of the Medicare explicit subsidy by plan. Again, this is calculated based on each plan's bid rate, and it's set at $183 or 50% of the bid rate, whichever is less. You also see the composite rate. So the composite rate is the single subscriber premium plus the Medicare explicit subsidy. You can also think about it as the bid rate plus the self-pay admin charge. And you can see on this table that 5 plans are now at the $183 subsidy cap. These are Kaiser Washington, UMP, United Complete, and the Primera supplement plans F and G for members who are enrolled in Medicare due to a disability. This slide is one we've presented before. This illustrates the impact of the Medicare explicit subsidy on the UMP Classic Medicare premium. We see that UMP has been at the $183 subsidy cap since 2022, and actually prior to 2022, but I only wanted to show a 5-year outlook here, or look back period. However, plan costs have grown in that time, as we know. This resulted in members bearing the impact of those year-over-year increases in their monthly premium. While UMP remains at the subsidy cap for 2026, the premium is nearly back to what it was in 2022. Without the transition to Part D, the 2026 UMP premium presented today would have been nearly $680 per subscriber per month. As I mentioned, I want to touch on the main factors driving down the UMP premium for 2026. The biggest piece is the pharmacy cost. As you may recall in past years, pharmacy represented more than 60% of the total bid rate, and that was prior to the transition to Part D. Now we're seeing that it's closer to 30%. So it was a major decrease to pharmacy claims costs. And within the pharmacy component of the rate, we saw lower prescription drug claims in 2024 and a better trend outlook for 2026, driving down the cost compared to the 25 rate development. So that's one of the big pieces of why you're seeing a decrease in the premium over 2025. Additionally, the IRA Medicare drug price negotiations take effect in 2026. So this is the first year we can capture that in our rates. We're expecting that these reduced prices for some of these high cost, high utilization brand drugs will result in a net decrease in claims costs. There will be some offsetting from reduced rebates, but overall, we think that this will have a net decrease on claims for prescription drugs. And then the other factor is one I've mentioned already, which is member retention compared to past years. Fewer members leaving the plan results in a more stable rate. The next slides introduce the proposed PEB Medicare retiree premium resolutions. When we ask the board to vote on the Medicare premium resolutions in July at the next board meeting, you will be asked to vote per carrier, which adopts all of the PEB Medicare plans offered by that carrier, as well as the premiums and the benefit design underlying those premiums. This proposed resolution would set the Medicare explicit subsidy at the cap that was established, that was set and funded by the legislature for 2026. $183 or 50% of the premium, whichever is less. However, the board does have the authority to set a lower subsidy. And I'm going to move through these pretty quickly. This proposed resolution adopts the Kaiser Northwest Medicare premium. This resolution would adopt the Kaiser Washington Medicare premium. This proposed resolution adopts the United Healthcare Medicare premiums. This adopts the Premera Medicare Supplement premiums. And now I'm going to pause a little bit because the UMP premium resolution is going to look a little bit differently. So as a reminder, last July, we had an exciting event. CMS announced a voluntary 3-year payment demonstration to offer additional federal subsidies to Part D plans to lower member premiums. And the intent was to kind of prevent all of these Medicare beneficiaries who are enrolled in Part D from switching their plans. The IRA was making changes to the benefit. Plans were having to adjust their premiums. Premiums were generally going up. And when members start switching, it really results in instability and can result in driving premiums even higher. So these additional subsidies were going to be offered to Part D plans starting in 2025. The status of funding for the second and third years of the demonstration, however, is uncertain. So CMS will make an announcement for 2026 later this summer.
Can I ask
Yeah.
would we have like an emergency board meeting if changes were so drastic that we needed to relook at it, or how would that work?
So 2 things. I'm going to give some information and then answer the question. First, it was the uncertainty of 2026 and 2027 was forecasted when the demonstration was made last 2025. So that's not a new development. There was very clear when the demonstration was created that exact funding and whether it would continue for years 2 and 3 was uncertain. So that was even when it was announced at the end of last July, the second and third year had a lot of unknowns to it, independent of changes that happened in the federal government after the last election. So the uncertainty is not a new piece. Second, we've actually, the resolution that's going to be presented would create the most flexibility for the state to be able and the board to be able to take advantage of any dollars that are continued in this demonstration project. Instead, we anticipate, we know a little bit about this variable. They're going to say a number or they're going to say it doesn't exist. And if they say a number, we're going to ask the board to have language in the resolution that gives the agency authority to immediately leverage and lower the premium if the federal government says this demonstration that you're part of continues to have funding in X dollars for plan year 2026, rather than having to call the board back like we did last year when it truly was a surprise event and there was no authority. So we see the variability that could exist here and are asking the board to give the agency the authority to take advantage of any announcement of dollars that comes under the specific demonstration. If there's something wider, you never know. We might, emergency board meetings can happen, but at a certain point, we are so close to open enrollment and having communications baked and printed and dropped in the mail that there's a point where depending on what the variability is, maybe no meeting. We're trying to we know this variable could exist. We have a reasonable path forward. And by not having to call a board meeting, it actually gives a few more days, up to maybe even an extra week worth of flexibility to take advantage of whenever an announcement could come from CMS. So the hope is to not have to call a board meeting if the board will give the agency the authority to immediately leverage an announcement within our operational timeline to say we can take advantage of it so that we have as much time as possible to bake that into the rates as possible.
All right, next slide. So let's see here. Sorry, I moved to the wrong slide on mine. So this is a reminder that standalone Part D plans are eligible for participation in the payment demonstration. This is why it doesn't include United or our Kaiser plans. Those are MAPD plans, so they're not standalone Part D plans. Our employer group waiver plan, our Part D plan, is considered kind of like a standalone Part D because we don't have the Medicare Advantage piece tied to it. And UMP elected to participate in 2025. As Dave mentioned, there was that special meeting that authorized the premium decrease. So moving on to our proposed resolution language, this adopts the UMP Classic Medicare with Part D premium, but allows HCA to lower the premium for 2026 if CMS continues the demonstration. So we have the standard language, the PEB board authorizes the UMP with Part D premium, consistent with open enrollment operational timelines. HCA has the authority to lower the 2026 premium if CMS continues the Medicare Part D premium stabilization demonstration.
Yeah, we'd be asking the board to take action on this resolution and all the other ones that Molly presented at the next board meeting, which is July
10th.
That was 10th.
We have 4 board meetings. We're preparing for
July
them.
10th.
We're on the 10th.
On the 10th.
10th.
Okay, great. On the 10th, we'll be asking for action. We don't anticipate that at the earliest that CMS would say anything about the demonstration until the end of July. And we were purposeful in saying operational timeline. So, there's always a little bit of wiggle room. And so we didn't want to put a fixed date in there and say, well, if we can get it in before, and we haven't actually hit print, like, can we take advantage of whatever timeline CMS comes? There will be a point at which everything is, literally at the printer and wouldn't be able to be changed. But this gives maximum flexibility for that without having to call an emergency board meeting to say, yes, you want lower rates. Because we assume that if you pass this resolution, you're fine with lower rates.
If going back to slide number 9, if the board were to change the allocation and there were savings, who has the authority to reallocate those savings?
The legislature.
So it can't be done internally. I mean, even if the board said they were going to change this to a lesser amount.
The legislature.
Okay.
Yeah. They would.
Not,
the money
that's not a board. That's not a
that's
board
not
decision.
fun money that we would have that we could do whatever we want with.
Okay.
That's from statute.
Yeah. I thank you.
Yep. Other questions for Oh, Harry. Harry has his hand up.
Yeah, thanks, Lou. I wanting to go back to the same slide that John just mentioned.
Slide 9.
I guess it was 9, yeah. What I'm wondering here, or suggesting here, is if we could think about maybe revising the wording in this such that we don't go through this every year, basically changing the date and the dollar amount, because that's what we've been doing for the last several years, and make it similar to what we did with the CDHP and just said that made it so we wouldn't have to redo the same thing every year. Hopefully that makes sense. I know it will to Dave.
Yep, totally tracking what you're saying, Harry. You're saying we found a way to thread the needle so that the board doesn't have to vote year over year to increase the high deductible health plan to match the IRS minimum that's required. This is the same, literally the same resolution every single year. The ceiling could change legislatively, but the only reason we've ever brought this resolution to the board is you technically have the authority to lower the cap. But to John's question a few moments ago, that doesn't give this board discretionary money to spend. It just puts savings into the state budget.
Yeah.
So we will absolutely take that under advisement and see if there's a way to minimize the need to have a vote on this. We'll work on some wording and see if we can bring something alternatively back so that the board never has to vote on this again.
Good recommendation,
Yeah.
Harry. Other folks, questions or comments from Molly? Molly, thank you so much. Appreciate it. Why don't we go ahead and take a 10-minute break? So why don't we come back at 10:20? All right, folks, we're back from break. Green means good. There we go. I like that. All right. Laura Topfer, is that correct? Topfer. Account manager in the Herb division is here to present proposed changes to the PEB program dental portfolio for plan year 2026. Materials behind tab number 7. Welcome.
Thank you. So good morning, Chair McDermott, members of the board. My name is Laura Tepfer. I'm the account manager for dental contracts. And today I'm here to present the changes to the uniform dental plan benefits that begin January 1st of 2026. Next slide. There are currently 3 dental plans offered to both PEB and SEB members. The Uniform Dental PPO plan, which is administered by Delta Dental, and there are 2 current managed care plans. The Delta Care Plan, also administered by Delta Dental, and the Willamette Dental Plan. And work to enhance the benefits to the Uniform Dental Plan began since last board discussions in 2022, and coverage between the SEB and PEB programs has not been identical since 2024. Next slide.
Yeah, Laura, I'll just step in for a second. Some board members who've had longer tenure will remember we had quite the meeting series, I think 3 or 4 meetings, talking about possible refinements to the Uniform Dental Plan back in 2022. That led to a decision package that the agency put forward, which I called the Choose Your Own Adventure decision package, because it wasn't a classic decision package that asked for a very specific thing. Usually a decision package is, here's a specific idea that's funded with exact dollars, and it's teed up as one individual like kind of yes or no review by both the governor's office and or the legislature. This one was here are the 4 to 6 possible changes that have been discussed without any true ranking of them, cost of different pieces, and kind of a pick and choose part. At the time that decision package was turned down or wasn't funded in the PEB program, there were different parts of it that were funded for SEB, in part because of how investing dollars were required under the SEB collective bargaining agreement that had been uniquely bargained at that table compared to the PEB table. And so there was the legislature and the governor's office decided to fulfill those CBA requirements in SEB by making some enhancements in the Uniform Dental Plan. That's why the plans diverged for the 2 programs at the time. And they diverged in 4 different benefit ways. And so since then, we've been kind of keeping an eye out and an opportunity to realign the offerings between the 2 portfolios. But given the budget environment we're in, we have to be very careful about the opportunities there. And so slow incremental progress, which I'm going to hand it back over to Laura to keep going.
So beginning January 1st, 2026, the 2 changes that we are going to be implementing in the PEB program, the UDP plan will begin to offer the same deductible and same temporomandibular joint coverage to PEB members that are currently available to the SEB members. These benefits are both already available to PEB and SEB members who are enrolled in the managed care plans, both the Delta Care Plan and the Willamette Dental Plan. So the only change we needed to do was to the Uniform Dental Plan. I also wanted to let you know the funding of these benefits was included in the 2025 to 27 operating budget. Okay, next slide. So the first change is to the waiver of deductible. The current PEB benefit is for $50 per person and $150 for the family. And the deductible does not currently apply to Class 1 services. Class 1 services are your preventive routine services. So your preventative exams, your cleanings, diagnostic x-rays, and fluoride and other sealants. Okay. The enhanced benefit design is that the same deductible for the family applies, 50 per person, 150 per family. And I have a typo in my slide that I just discovered. So the deductible does not apply to services. It should not say Class 1 in there. It does not apply any longer to services for children under age 15. Yes.
Does that mean that the deductible would apply to adults for preventative exams and cleanings going, or is this just an additional all things for
Deductible
children
does
under
not
15?
apply to Class 1 services regardless of age currently. And we're expanding that so that for children, it will apply, it
All
will
things.
not apply
Okay.
to all services, preventative or others.
Okay, thanks.
So when it comes to deductible, the only thing that's changing from today to January 1st is there's no deductible required for children under age 15. Everything else about the current plan design with regards to deductible, age, adults, what counts, doesn't count, all that stays the same. The only thing is kids under 15 are free, no deductible, so to speak. Free, so to speak, no deductible. Did my prepositions backwards.
Okay, next slide. Second benefit change is to the temporomandibular joint services or TMJ services. The current PEB program benefit is that the member pays 30% of their allowed charges and then any amount over the annual max of $500. And there's also a lifetime maximum of $500. The enhanced benefit that's currently in SEB is the member pays 30% of the allowed charges and then any amount over an annual maximum of $1,000. And the new lifetime maximum benefit will be $5,000.
Sorry, one more, and this is, I'll just acknowledge this is a personal question, but for the slide for the deductible not applying to all services, does that include braces? Or is orthodontia different than dentistry?
My understanding is that it's all services.
Okay. Thank you.
And again, we're just talking about the Delta Care plan.
The uniform dental plan.
I'm Uniform Dental Plan rather than all three.
Right.
So just to orient a little bit, I think of the dental benefits in the two portfolios as like 4 quadrants. We have self-insured, PEB and SEB as the top 2 quadrants in my head, and fully insured, which is Delta Care and Willamette, PEB and SEB, which are my bottom 2 quadrants. The first change that happened were these 2 changes were made and proposed for SEB self-insured. And when that change was made in 2024, the fully insured carrier said, we'll match that in SEB. And while we're doing it, we're not going to do something different for SEB and PEB. We'll just go ahead and do it for PEB fully insured at the same time. So that took care of 3 of the quadrants. And then we're coming back to cover the last quadrant, which is changing it for PEB self-insured. That's for these 2 benefits. There's still 2 other benefits I can highlight that are different between PEB and SEB. You might be wondering, a reminder of what they are. In SEB, the crown coverage is 70%. The plan covers 70%. The member covers 30%. And in PEB, it's 50% and 50% split. And then on SEB, they have composite filling for back teeth. So the difference between amalgam and porcelain type fillings. The coverage, the allowed amount that is reimbursed in PEB assumes an amalgam filling in the back teeth. And so any difference between amalgam and porcelain or the ceramic filling is fully passed on to the member if they want to not have an amalgam filling. But in SEB, the baseline for reimbursement is not amalgam, it's composite filling. So that incremental difference is paid for via the allowed amount and then the cost of co-insurance by the member. So it's a higher reimbursement rate that, is now split for composite fillings and back teeth on SEB. So those are the two differences after these changes that will still exist, and we will keep looking for opportunities. The cost for these two different benefits was very small. And in the budget environment, I think I highlighted this as Tanya was doing presentations earlier this season. When we look at these programs, we think about how they're funded with the funding rate. That's the big number that Tanya always presents about. And if a benefit change doesn't, or the totality of benefit changes in any given year doesn't require an even $1 adjustment in the funding rate, then the legislature and the governor have the ability to just say this fits within existing rates. And that's language that they did include in the budget for 25-27 on these two changes, because the totality of these plus doula coverage that was presented by Tanya earlier this season, the totality of all of that didn't rise to the level of needing to adjust the funding rate by even $1. So that's what we are looking for, and the opportunity we saw is to make a small change that helps align these portfolios. We always are looking at alignment between the two portfolios and alignments between the our portfolio and the general fully insured commercial market. So anytime there's variances there, we're looking for opportunities to try to create as much alignment or be ahead of the curve and push the envelope on different benefit designs, and hopefully the rest of the market then catches up to the PEB and SEB portfolio. So just a little bit more right there.
Harry's got his hand up. Harry?
Yeah, thanks, Lou. Dave, you brought up a point that I think is worth considering. I don't know what the cost would be, but seems to me, my limited experience is that many dentists won't use amalgam anymore. And so, in the past, composites have been used for the front teeth, so to speak. So I'd be curious if we could find out for down the road what the cost per member would be estimated at to allow for composites throughout, or entirely, since again, I think my experience is that a lot of dentists don't want to even deal with the amalgam. Thank you.
Yep, Harry, totally agree. That was part of when we had the conversations with both boards back in 2022. There was discussion about kind of standard of care amalgam. A lot of places don't even offer it. And so then that cost difference, we're paying as if it's pretending it's amalgam for reimbursement purposes and paying as if it's amalgam. And then that full cost difference is there. And that is an inequity in the system that was, trying to be addressed. It's definitely on our radar for an opportunity to make that change and pitch for when that change should happen. We will look at if I remember right, it's close to or just above about $1 in the funding rate. So it is kind of like right on the cusp of like fitting, but probably not fitting within the trying to make an adjustment in the same way that TMJ and children deductible waiver is, but we could certainly bring that, and it's on our radar because it really isn't the standard of care at this point, and we long term and hopefully shorter term than long term in the range of a long term timeline, hope to be able to make that adjustment. So we can definitely bring back some information to share what those cost projections are. The other option that we always have is to look at if there is a, we've talked about how the board has like benefit swap authority. You can reduce something over here and pay for something over there. We're kind of have this in the back of our mind as well as like if there's an opportunity or something where there is some sort of adjustment and benefit design that has an offset that might be able to be used. We're kind of monitoring that as well. So we're actively looking for an opportunity to align these pieces, and composite dental back posterior teeth is definitely on that short list.
And my next slide was just, do you have any other questions?
Any other questions for Laura?
Thank you.
Thank you.
you.
Appreciate it.
I do have one more comment. I keep
Okay.
thinking of things.
Yeah.
So remember, these benefits for employees are employer paid benefits. So the premium is fully paid for by the employee. For anybody who's self-paying, there will be an incremental increase in the rate that, like a retiree who's aligning and buying uniform dental, as well as anybody who's on COBRA. Tanya will present those rates. It is a small incremental difference, but that was something that was also discussed previously at board meetings, is that this is a benefit that would be across the, it's the same benefit across the entire population, and that there was value added. I remember Elliot saying, I want to support my grandkids, or the, retirees want to support the grandkids. And so waiving a child deductible, if it's a very small amount, but Tanya will go over that whenever we present the rates. So I did want to just remind people that self-pay, they will see a small incremental increase related to this, but and it exists on the bids for the employer paid benefit, but employees won't see that because it's fully employer paid.
Okay.
So this is the same plan that retirees would have?
Correct.
So I hate to ask this question. If you retire from the state of Washington, but you don't have health benefits when you retire, can you keep this plan? David and I have
Yeah.
talked about this before. I just thought you might have the answer.
You mean dental only?
Yeah.
Is there such thing as retiree dental only? Yeah.
Even though you pay for it separately as a retiree.
And since Laura's not near a microphone, Laura, I was helping pinch hit. Yeah, too many Lauras in the room. Laura Ryan, who presented earlier, was reminded that there is no such thing as dental only enrollment. In order to be enrolled in dental, PEB retiree dental, you have to be enrolled in PEB medical. And John's asking, with those being separate premiums, I think your underlying question is that a policy that can change? What's the justification for that policy? And can something maybe come back to the board about that? And so we will put that on the formal to-do list to bring information to the board. What the current policies are, you must be enrolled in medical to also have the opportunity to enroll in dental.
Great, thank you.
Other questions or comments?
Yeah, I have sort of a questionable question. Seriously, has the Washington State Dental Association weighed in on this? And I don't know if it's within your authority, but I would think, based on what Harry said and based on my experience too, I forget if they were called composite or whatever, but it's the new stuff, this issue would be of importance to them.
Yeah, well, I don't think there's been formal, well, I know there have been formal conversations there. I don't think there's any dispute about like the general standard of care, what's actually being offered in dental facilities. It's the reimbursement mechanism treats it as if it was amalgam. There's still payment, but you're kind of in a situation where most members can't even access an amalgam filling. So it's changing the reimbursement policy, and sometimes reimbursement drives the services that are provided. In this instance, the service is being provided generally as a composite filling, and you can't even get amalgam, but the payment mechanism hasn't caught up to recognize that standard of care within this part of our portfolio. So it's not that this is an instance where our essentially outdated from a standard of care perspective reimbursement policy is minimizing the innovation or the advancement or utilization of composite in the market. That's happening independent here. We're trying to catch up the reimbursement policy to reflect that standard of care.
But can't this, I don't know how to put this, can't this help the dentist's income? And do they have an interest in that if this change is made?
Well, I mean, when the member, if the dentist is only offering composite and the patient proceeds with composite and they're on UDP dental, they're getting composite. It's just the member is picking up the differential. And so this change in reimbursement that would happen wouldn't change the amount that the provider ultimately gets, because it just changes that they're getting more from the plan instead of from the member.
Okay, got it. Thank you.
Other questions or comments? All right. Thank you so much. Appreciate it.
Thank you again.
Next up, Kelsey Pele, Senior Account Manager in the PEB Division, is going to provide some information on PEB program's collective bargaining flexible spending arrangement benefit that will take effect for eligible subscribers in the 2026 plan year. Materials behind tab number 8. Kelsey, welcome.
Thank you. Okay. Good morning, Chair McDermott and the members of the board. My name is, like you said, Kelsey Pele, the Senior Account Manager for the Flexible Spending Arrangement and the Dependent Care Assistance Program benefits that we offer our PEB and SEB employees. And I am here to give you some updates on the PEB program collective bargaining flexible spending arrangement. All right, next slide. So first off, I'll start off by just reminding everyone of kind of what a general FSA is, flexible spending arrangement, FSA. I'll use the abbreviation. It's a long term. The FSA is a tax savings program that allows FSA funds to be deducted from employees' paychecks before taxes to reduce their taxable income. And some examples of eligible out-of-pocket healthcare expenses that employees can use their FSA on are their deductible, copay, coinsurance, prescriptions, first aid supplies, sunscreen, vision hardware, and more, much more. Employees can elect a maximum of $3,200 in their FSA funds for plan year 2025, or a minimum of $120. The election amount is subject to annual Internal Revenue Service IRS cost of living adjustments. And an important note, especially in regards to the CBA FSA benefit that I'll be talking about today, is that funds contributed by an employer do not count towards the maximum allowed election amount. All right, next slide. Okay. So the FSA benefit uses the carryover plan design. That began in January of 2023, and this allows unspent funds to be carried over and made available for use in the next plan year. So the carryover limit has increased for plan year 2025, and that amount is $660, which will be made available for members in January of 2026. So this is an increase of $20 from the 2024 carryover limit, which was $640, that was made available in participant accounts right after in January 2025. And as you can see here, the carryover limit has increased each year and will not decrease. So for FSA participants to receive carryover, they must enroll in an FSA for the following plan year or have at least $120 left in their account on December 31st. So any funds below that 120 minimum, if they do not re-enroll, or above that 660, regardless of their enrollment status, will be forfeited to the HCA due to IRS rules. I will also call out that in each fall, the IRS sets the new carryover limit for the next plan year. All right.
I like to highlight, what happens to those forfeitures when they come to the employer, or in this instance, HCA on behalf of the state under IRS rules. We use those primarily to pay for the administrative expenses of our contracts. We actually have a really low forfeiture rate compared to Navia's book of business. They always highlight how low of a forfeiture rate, and one of my goals is to have that rate as low as possible. To me, it's really important, especially the employee elections, that those dollars are actually going to and used by the employee. But we have a very small forfeiture rate, and it has, as far as I'm aware, has never exceeded the administrative cost of the contract on an annual basis. So this isn't an area where there's some sort of profit that is suddenly realized or revenue that's realized by the state. It's not that type of thing. And like I said, it's really important to me personally to drive that forfeiture rate down as much as possible. So.
All right, next slide. Okay, so now let's dive into what the PEB collective bargaining FSA employer contribution is, who it's bargained for, and the stakeholders involved. The benefit was bargained for certain PEB employees to receive funds in a flexible spending arrangement account. HCA designed this benefit to ensure compliance with the collective bargaining agreement and contracts with Navia Benefit Solutions to administer the benefit.
Navia Benefit Solutions creates and manages participants' accounts as they are our FSA and DCAP vendor. And the PEB program employing agencies and labor unions play a key role in communicating with us about this benefit. Next slide. Okay, so there's kind of two layers of eligibility requirements for the PEB CBA FSA employer contribution. First, members have to meet salary and union representation requirements and then meet PEB program requirements as well. So for the union and salary requirement, the Office of Financial Management determines those pieces, which is that each bargaining unit member must be represented by union in the coalition described in RCW 4180020. And then eligible recipients must be in an annual full-time equivalent base salary of $60,000 or less on November 1st of the year prior to getting the $250 FSA. And then the second layer of eligibility requirements is that the PEB program will apply these following requirements, and that is that they cannot be enrolled in a high deductible health plan in the same plan year, and they cannot waive their enrollment in a PEB medical plan except to be covered as a dependent on another PEB non-high deductible health plan. So if all of those eligibility criteria is met, then the PEB employee receives a $250 CBA FSA employer contribution in January. And that's how it stands as today. All right, and let's go to the next slide and I'll kind of describe the changes coming up. So starting next calendar year, effective January 2026, there are two changes happening for this benefit. One is that the salary threshold increases. So the rate of pay on November 1st, 2025 is $68,004 or less for a full-time equivalent position, which is an increase, as we know, as we saw on the previous slide, $60,000. So this will boost eligibility since more folks will be able to become eligible for the benefit, casting a broader net by including more folks with a higher salary amount. And then the other change to the FSA employer contribution is the fund amount. So eligible represented PEB employees subscribers will receive now a $300 FSA amount in January, which is obviously an increase from the $250 that we have been seeing since the inception of this program. And the inception of this program was January 2020. Lots of things happened in 2020. All right, next slide.
I was just going to add, you might wonder why $68,004 seems like a fairly specific number. And that's because it's the number closest to 68,000 that's easily divisible by 24, because the number of pay periods for most state agencies and state employees, not at higher ed, but at state agencies is 24. And so we like nice round numbers that get to 50 cents or whole dollars when you divide by 24. So.
Thanks, Dave. All right. So yes, how the CBA benefit works. One of the key takeaways about this benefit is that eligible PEB program CBA recipients are not required to actively enroll in an FSA to receive the CBA FSA funds. If the eligible PEB program subscriber does not actively enroll in an FSA, there's going to be a customized CBA welcome letter and FSA debit card with the funds loaded on it, and that will be available to available for them to spend eligible healthcare expenses on right away. The CBA FSA welcome letter and the debit card are sent by Navia Benefit Solutions to the subscriber in mid to late January, after HCA sends the final eligibility list of recipients to Navia. Participants will also be able to use Navia's portal to manage their FSA benefits and can submit claims for reimbursement, just like general, people that do enroll in the FSA. They're members too. So they get the benefits there. And then next slide, it's just a continuation of how it works. The eligible recipient, are not are required to actively enroll in an FSA to receive it. But if the recipient did actively enroll in an FSA during annual open enrollment for 2026, the $300, I should say, contribution will be added to their existing account with the funds they elected. Also, an important call out to make is that the employer contribution will not come out of the employee's paycheck. Simply just given to them. All right, yep, next slide. So this slide depicts the Navia Benefits debit card that I mentioned in the previous slide that they get in January if they don't already have one. That's valid. New FSA and or dependent care assistant program participants and existing participants with an expired debit card are issued this debit card here. The debit card has the HCA icon on it and the PEB program written on the top. And the intent here is to really help PEB, CBA, FSA recipients make the connection and recognize that this debit card is not another scam coming in the mail, but it's a part of a real benefit offered to the PEB program and their employer through Navia Benefit Solutions. So recipients will receive that welcome letter right before receiving the debit card in the mail. And so the intent really is to have them read their welcome letter that explains the benefit, what this is for, why they received it, and to look out for that debit card in an unmarked envelope in the mail with the navy blue Navia debit card in it, and so they can use their funds right away. Next slide. All right, so rounding off my presentation with a couple of data type slides, first being a table that shows each plan year and the number of eligible CBA FSA recipient subscribers that receive the $250 CBA FSA for the plan year since the beginning. This is after OFM and HCA have gone through the initial data set and applied the eligibility requirements. So in other words, this is the final count of recipients for each year. So in 2020, there was 18,560 eligible recipient subscribers, and then eligibility kind of trended down in 2021, 2022, and 2023, as you can see here. I'll note that on November 1st of 2023 was when we had a new salary threshold increase. It went from $50,004 to $60,000. So come plan year 2024, the numbers almost doubled from 2023 to 2024. So you have 19,111. And then for plan year 2025, there was 16,906 recipients that received the 250 CBA FSA funds. And then the salary, as we know, the salary threshold is increasing again from $60,000 to $60,004. So we assume, come January 2026, the number of eligible recipients will jump back up, increase like it did in 2024. All right.
Overall, there's been a rough goal of trying to maintain roughly the same number of subscribers that had the access to these funds as when the program launched. I was sitting here thinking about the timing of this, and when you look at a plan year on this, realize that the collective bargaining process that influences that year is actually 2 years earlier. So you might go, if in 2020, it took until 2024 for there to be an adjustment. The 2022 plan year was the first year under the collective bargaining agreement that was bargained in the summer of 2020. And the philosophy of the state at the bargaining table at that time very much was there was a lot of uncertainty. You all might remember why. All you have to say is 2020. And so but there was an acknowledgement at the next cycle in summer of 2022 of a goal to get back to the same volume of individuals that had been available or received this at the beginning, and that's where that first adjustment then hit in 2024. It's very hard to like the time travel aspects of the program, but the bumps and enrollments really are related to decisions that are made 2 years before.
Thanks, Dave.
Mm-hmm. And a reminder that this is only an employee benefit because it's all rooted in typically in payroll deductions, except for this employer sponsor piece. So there is no access to FSA and DCAP benefits for retirees. And then another question that I think some people have been asking recently is, how much can an employer put in? Is the sky's the limit? Could you just put $10,000 in these? And the answer is no. There are IRS rules about everything when it comes to taxes, of course. And there is a limit that an employer can have a seed contributions to an FSA before it becomes a qualified group health plan.
I believe it's $500.
And it's $500 right now is the cap that could be. So there is a finite amount of space for an employer to work in this area. And it's an area that when we talk to our tax legal AAGs, they've seen as something kind of innovative that Washington State has done that isn't really done many other places. And our Navia has said the same thing, that they don't have a lot of other customers who do this type of thing, targeting seat contributions to lower wage workers in the way. It's actually interesting. In IRS rules, you have to pass non-discrimination testing so that you don't overly benefit highly compensated individuals, as the IRS defines that term. But here we're actually targeting lower wage workers to be able to subsidize costs. And so it's something that kind of is unique that our state does.
Yes, sir.
You manage the entire FSA program? Is that
Yes.
okay? So what happens in the case of an employee who blows through their maximum? Not
For
just
the
the
plan year.
for the whole year, plan year, in the first 2 or 3 months of the year,
Mhm.
and then leaves the employment of the state.
They win.
But
They win. That's
who
right.
pays for that? Is that part of Navia's contract? Is it paid for by PEB?
So a few minutes ago, I highlighted that we use the forfeitures to offset plan administrative
That
expenses.
would
The
be-
other part that those forfeitures help offset is the risk that we as an employer have for individuals
Okay.
like you described, who have used this pre-funded benefit. So pre-funded meaning it's all available on January 1st when the plan year starts. They use all of the benefit before they've had most payroll deductions happen.
Mhm.
So in the instance you described, John, I'm going to do round numbers. Let's say the maximum was $2,400.
Yeah.
And so there's $100 coming out of every
Yeah.
paycheck. If they have an orthodontia bill, Magila, that costs $2,400, and they pay that by the end of February, they've only put $400 into their
Yeah.
fund, and they have $2,000 projected for their deductions for the rest of the year, but they cease or lose employment with the state as of March 1st. The state is on the hook for that $2,000
So
because
it's the state,
it-
not the Navia.
yeah, it's
Right.
it's not
Not
Navia.
your
And so
contract,
the
okay.
forfeitures take into account that risk. And it's one of the reasons, the policy reasons, I understand that the IRS, that the federally it was set up that way, is there is a risk. There's a benefit to the employer to offering FSA, but there's a risk. And one of the big risks is what you just described, John. So the forfeitures for, and I couldn't think of that like 2 minutes ago or 5 minutes ago, what the other thing is that we use forfeitures for, but it's to offset the risk of the exact scenario you described, as well as admin expenses. And that I feel confident between those two things, we've never had forfeitures that high.
Contracts, where it's the insurance company
Mhm.
or the administrator that takes that risk. But in our case, it's the plan sponsor.
Yep. It's HCA. But our forfeiture levels are low, and they have never exceeded both the risk related to this scenario across the population, nor the admin expenses of the actual contract.
Right.
Slide.
Yeah. Any other? Okay. Next slide. Okay. So I'll explain this table a bit. So I'll start at the top. The total CBA FSA fund eligible recipients represents the total number, the final list of recipients after HCA and OFM have both scrubbed the data, and it's that final set, the data, final list that we give to Navia at the beginning of the year to apply the CBA funds to those recipients' accounts. So then the CBA only recipients are those folks who did not actively enroll in an FSA. So that's the amount of CBA recipients who received the CBA FSA funds in January, but they didn't enroll in their own FSA elections during the annual open enrollment period. So you can really see here that many of these folks that received the CBA FSA funds in January do not already enroll in an FSA during the annual open enrollment period. So then we see numbers and percentages as well, and they're kind of staying stagnant as the year goes on. But to track utilization of this benefit, we have kind of 3 different categories. We have those who have used some of the 250, used all of the 250, or used none of the 250. And you can see that there are actual numbers of how many in each of those categories, and then the percentages of are taken from the total. So the one change that I really want to keep stressing and decreasing is the use none of the 250, right? We want everyone to know about this benefit and use it. So in 2020, 42% used none, then 41% in 2021, 56 in 2022, 63 in 2023, and then it's decreased back to 54% in 2024. And I will call out that, yes, it's 63%, but that's through June of this year, and we do expect that number to continue to decrease as the year goes on. People, use the benefit as the year goes on. With the other two categories, use some and used all. I think it's safe to assume that if they know they have the benefit, that's when they know they have the benefit because they've used some of it, they've used all of it. And we just need to make sure that they're knowledgeable about carryover and how that may or may not apply, depending on how much they've used and if they did not enroll into an FSA.
We do collaborate with the unions to produce communication materials that both they can use and then that we use. And we do promote this benefit through benefits administrators at state agencies as well. So it is a goal to continue to use and get people to be aware of this benefit. I will say the other piece that I was thinking about, it just escaped my mind. What was I going to say? As soon as I turn off my mic, I'll think of it. Didn't work. Yeah.
And sorry, I might have missed it. Maybe it was covered, but knowing that we're going to be voting on a resolution to increase the kind of maximum amount for people to qualify for this, and that kind of as a state, we're continuing to want to support low-wage workers. Is there, like similar how Tom recommended before, is there a way to potentially propose the change so that we don't have to keep voting each year?
The board doesn't actually have the statutory authority
don't?
related
Okay.
to this benefit.
Okay.
And statute, this is one part of the portfolio that is exclusively set up as under the agency's jurisdiction for benefit design and maintenance. So there are no votes, but we, like I said, it's related. And the original idea behind the FSA benefit was to have an amount that matched the deductible of UMP Classic, the plan that most people are enrolled in, but not everyone. And so it's collectively bargained by the state. The statutory authority is the agency. So we're just sharing the information with you. And just like that, I remembered and forgot what I was going to say again. But it's a little idea. It was. I'm going to think of it again. But John has a question. I'm going to write it down when I remember.
Yeah, I apologize for asking a lot of questions, but my experience at the University of Washington was that we didn't know about this or we didn't focus on it. Because we have a union and non-union group of employees, number one.
Right.
Number two is a large portion of the people that would qualify.
Yeah.
English is their second language.
Yes.
And they just, I'm just so difficult to communicate, but this is even more difficult
Yes.
to communicate.
You know, it's really great that you brought that up. At a recent labor meeting, we had a UW rep say, can we get some of these documents, these communication materials in 3 different languages? And they said Spanish, Tagalog, and East African, and I cannot remember the East African Trinidad. It wasn't Somalian, it was Tigir. Okay, hold on, I have it in my notes. Tigrinya.
Good luck.
But anyway,
3 languages.
3 languages that they mentioned that those are the top 3 languages that people speak, and UW is they have the most CBA FSA participants on the PEB side. So we're absolutely working with Navia to get the customized welcome letter in those 3 languages, and then Alyssa, I just emailed her yesterday about this to get a few more documents in translated services, and also letting our BAs know how they can request this too. Because I don't think I can certainly do it on their behalf, but if they know how to do it for their employees, I think that would be beneficial as well. Part of our communication tactics.
Yeah, we don't have a lot of materials that we proactively automatically translate into other languages.
Right.
We have been heading in that direction on key things. We recognized a pattern of a lot of the enrollment guides were being asked for in Spanish every year. So now when we finish the enrollment guide, we go ahead and do that one. This area, because of the state's unique interest in why this was collectively bargained and the reason that the governor's office and OFM supported this in its originality, we said, oh, this as employers are like UW are bringing us, this is a way to help increase access and understanding of it. We're working on proactively translating some of the key materials as well. And I finally remembered and wrote down what I was going to say before, which is because of the level of individuals who have not used any of this employer contribution, that was one of the driving factors to change the benefit design of this structure to have the carryover rule. Because by having a carryover rule where Now $660 can roll over. We buy ourselves all collectively more time to help educate this population that they have access to it, because they won't hit the forfeiture until at least year 2 or 3, sometimes even 4, depending on how inflation drives IRS changes. It gives multiple years for that seed money to grow a little bit and not forfeit those funds. So that design was very purposeful and ultimately kind of like the tiebreaker that said, let's move to the carryover design from the other design that the program used to formerly have for this benefit.
And
it was to
HCA
be more employee friendly on this front.
And we always accept the
Yeah, and
the
we
highest carryover limit.
we always automatically accept the highest carryover limit. The IRS produces that information usually really late in the process after open enrollment has begun. But since that doesn't impact benefit elections in any way, we just automatically incorporate that and accept whenever the IRS raises it de facto for the next plan year. Again, driving down forfeiture volume as low as possible.
Any other questions for Kelsey?
Thank you very much.
You're very welcome. Thank you, everybody.
Thank you. All right, next up, we have our benefits 24/7 update. Brett Mello, our CIO for the Healthcare Authority, and Alyssa Richards, benefits account section manager in the ERB division, is going to be providing us the latest information on the agency's work on benefits 24/7. Materials are behind tab number 9. Brett, Alyssa, welcome.
Well, good morning, Chair McDermott and members of the board. Again, I'm Brett Mello, Chief Information Officer at HCA. So I wanted to just give you another status update, the work that's being done in support of benefits 24/7 development. So we have completed our stabilization effort that we've been working on for a number of months. And we have achieved, actually far achieved the goals, the metrics there in that middle section that we had laid out. Very satisfied with that progress. There's still more that we want to and need to continue to improve on this. So while we've completed our stabilization work, we are now working in how do we continue to advance and optimize our system going forward. And I'll get into that just a little bit more. I'll give you an example of that in a moment. Also, just a quick staffing update. So we are actively, actually, we should probably be changing that to interviewing. So we've identified candidates for our manager role. And just as a reminder, we have redesigned our teams a little bit to bring them under a single manager. And those teams would be Benefits 24/7 Development Team, our Pay One team, our testing team, and our business analysts that help gather requirements and things for the solutions to be developed under. So having that group just coordinated under a single manager just made a lot more sense and would expedite the work of those different groups of folks. So we're starting interviews up soon. 2 weeks, I think. Yeah. Okay. All right. So we're getting going on that. And then we've got some other positions here, analysts, and that we're drafting the positions descriptions, and we're hoping to start filling those positions soon. So.
And these were all positions that were part of the decision package that was funded in the last operating budget that Tanya has been highlighting along the way and that I've been providing some commentary on. There were 6 ETS positions, and this is 5 of the 6 that are being worked on. We actually pre-hired and anticipating that the answer wasn't going to be 0 as a result of that decision package. And so that 6th one actually already exists and is part of the team already.
Sounds good. Next slide. So a part of the work that we're rolling into now is to prepare for open enrollment this fall. So the teams are transitioning their work to prepare for all of that, doing annual updates in the system, specific things like sunsetting UMP Plus, doing language updates and stuff like that is all a part of the work in preparation for open enrollment come October. We'll still be working on bugs as they come in. As we identify things, we will obviously continue to work on those and prioritize those appropriately. We also have a focus group of benefits administrators that's helping us improve our OE, our open enrollment wizard, to make that even better. And then as noted specifically around dependents and spousal attestation. So going through as we get closer to that time period, doing our appropriate testing to make sure that everything's working in our systems so that we have a very smooth open enrollment period.
And I'll just add our benefits focus groups are really those pieces that are talking about improving the wizard are drawn from direct feedback that we receive from benefits administrators after open enrollment about some of the challenges and maybe confusion and user experience around specifically adding dependents and spousal surcharge. I do want to also highlight that we aren't waiting to put up things about UMP Plus. We're just finishing up language because we want to make sure that new employees who are looking at plans know that if they pick that plan, they're going to have to pick another plan by the end of the year. So we already have some language that is going to be integrated and added into benefits 24/7 shortly if it hasn't already deployed. I think it starts up the list of just mouth today. So there'll be language that kind of previews that for folks just to kind of orient them already. So
Sounds good. Next slide. So one of the features that we have wanted to in the past, but now we're focusing on or preparing for, which will come a little bit later, certainly after open enrollment, but is basically creating an interface to automate the intake of enrollment information, demographic information, and so on. So, because right now it's a very manual process, a lot of keying labor to make that happen. And so focusing on how do we automate that? How do we create an interface so that the data flows near real time from an organization's system, HR system, such as UW and Washington State, getting ready for that. So we're starting to do the groundwork for that. The initial launch won't start until after OE, so it'll be spring of next year, but we're laying the foundation for some of that now, doing some of that work, and preparation for that coming this following year. So that's a little bit of where we're going next.
I'll just add another like 50,000 foot level. I can't help myself just to add a little bit more. So this API work is next on the to-do list, specifically because University of Washington data isn't in benefits 24/7. So the way data travels in this agency for PEB and SEB is it starts in benefits 24/7, goes over to our pay one system, and then that's the system that does as our accounting record and produces carrier files out to the carriers. And one of the things that we've been working on with stabilization is the inherent challenge of syncing data from a system built a year ago and launched a year ago to a system that was created in the late 70s. With that, when we launched benefits 24/7, we needed to and actually reverted UW to actually putting their data directly into pay one like they had been for decades to reduce the amount of errors and syncing issues that were happening with the largest employer in the PEB program. But in order to continue modernizing the entire system, we've got to get UW's data directly into benefits 24/7 so that then we can continue to add functionality to benefits 24/7, like having the carrier files produced out of that system so that it doesn't require syncing data over to our old system. So this is kind of like slowly retiring some of the key parts of the system. API specifically for UW is step one in order to be able to move carrier files and migrate other functions out of the pay one system. So that's why this is kind of front and center. But we're doing this in a way in conjunction with both UW and WSU, because WSU also has the Workday system that UW uses and wants to be able to have a more integrated system there. We also have multiple local government employers in PEB that are interested in having more integration. So this foundation that's being set by ETS and Brett and his team is to be able to have a singular API approach informed by multiple higher education institutions that then is a template and blueprint for using for other integrations in the future. Michaela, you have a question.
Well, I'm just going to apologize in advance because this is going to show my lack of tech knowledge.
You're fine.
But knowing that, like you were saying, UW and WSU have moved over to Workday, and that the state of Washington, like general government, is planning as of now to move to Workday, if there's any opportunity for the business owner, my team, to partner to try and understand how this works so that we can kind of influence that into how we do our kind of business cases in the future. Would love to have that opportunity to learn what it looks like so that we can think about that as we still do our readiness work.
Plenty of opportunity for collaboration there.
Without a doubt.
Okay.
Good morning, Chair McDermott, members of the board. For the record, my name is Alyssa Richards. I'm the Benefits Account Section Manager. So just a couple updates on communications. We had been sending out weekly communications to our benefit administrators, letting them know of current issues we're working on, things that we've resolved. And we are, as of Friday, we're going to start sending those communications on a monthly basis as we're transitioning to that open enrollment preparation work. So we'll continue communicating on a monthly basis. However, if things come up, we'll definitely be communicating more often as needed. And then also just wanted to note that all of these historic communications that we have sent out to the benefit administrators are posted on the benefit administrator website, so they can be accessed at any time. And that's what I have about that. Any questions?
Any questions for Brett or Alyssa? Thank you, folks. Appreciate the update.
Thank you.
All right. Next up, we're going into public comment. Do we have anybody in the room who's going to be providing comment? All right. So we are looking for individuals to put their Zoom hand up. We will call your name. We will give you the ability to go audio and video and provide your comment. So looking for anyone who would like to provide public comment today. Going once. Going twice. All right, seeing none. Our next meeting is going to be July 10th, 2025, starting at 9 a.m. with the same format of attendance in person or via Zoom. Dave, any final comments before we adjourn?
As a preview of coming attractions for July 10th, we, similar to today, will actually start with a brief executive session. We think there may be some updates to give you on the rate development process on the non-Medicare rates as we then later present those in that same meeting. So we will have a similar design of a brief executive session at the start of the meeting. We'll bring back the resolution and follow up from Ryan today about UMP and hearing instruments. We'll have Molly back with all of the various resolutions on Medicare premiums, including our by then rewrite of how we can have you vote on the subsidy cap one last time instead of every year forevermore. So we will take that back to heart per Harry's suggestion. We will also be previewing and teeing up the non-Medicare plan design changes, as well as the non-Medicare premiums and those resolutions, which we will then ask you to act on at the subsequent July 17th board meeting. So next meeting is vote on Medicare, learn in public about non-Medicare final rates, and then vote the subsequent last meeting of the season on the non-Medicare rates. And next meeting, we will also be squarely talking about the 2026 board season, sharing with a schedule that we are proposing to move forward with so that we can then file it. There aren't too many surprises on the PEB side. We're actually working on changing the meeting cadence or some of those ways we structure things on SEB a little bit, but we've always tried to keep PEB as stable as possible, knowing that the most engaged members of the public for us are our retirees, and we think stability in meeting times and places and locations is a good thing to facilitate that continued participation. So we will adjust things on SEB, but we will preview the board schedule for 2026 before it goes out for filing for next season. And with that, I believe we are at the end, and I hand it back to you.
To clarify, we're not going to have a meeting on the 24th or the 20.
At this point, I can say we are canceling the July 31st meeting, absent something unusual or unexpected happening. 24th is really unlikely. Once we are at the 10th meeting, I'll feel more confident in saying officially canceled. So it's on the bubble. 31st, I think we can take off the schedule. 24th will confirm next meeting. Unlikely, possible, but unlikely.
Thank you.
Any additional questions or comments for Dave? All right, Dave, thank you to you and your staff. Again, great presentations. Thank you for the board members who attended today, and this meeting is now adjourned.